Hope I am audible. Okay, so let's begin. If you have any doubts, you can post in the comment section. So today we are starting the very important chapter of breast. We will try our level best to cover this chapter, maybe in this one module or another half module tomorrow. I want to cover it up very fast because I think there are many sources which are currently teaching breast, and you might have already read it from the different standard textbooks as well. So many things is that you need to have a concise and compiled information together. That does not mean that it should be from scratch, because obviously you have different sources of learning, and we are going to try to revise, and we are trying to get everything into one place so that you can connect the dots which you already know. If you don't know, obviously, so you can go back, you can study the basics of the breast. It starts from the anatomy, pathology, and once you are going to read that, then surgery might feel complete. So there are few factual things which you might have to remember. I'll help you memorize them. I'll try to relate it with the anatomy, physiology, and I'll try to make it more easy. But basics is you will have to somewhere or the other understand that this is going to be a kind of a revision session wherein everything is going to be clubbed together, and we'll try to make maximum utilization out of it. Because I had many doubts after entering the residency that what is actually breast about, how are you going to manage the breast diseases, what is the actual condition you should think about, and many things. So whatever I have figured it out, I have given it to you as it is. So I hope we can start off with a very good very good hope. So what is a TDLU? So TDLU is nothing but a terminal duct lobular unit. So you know that the breast is going to be consist of a nipple areola complex. So if you can see the diagram very well, so breast is going to be composed of a nipple areola complex. So here you can see that it is a nipple areola complex. There is going to be the duct, and this duct eventually is going to end up, the duct is eventually going to end up into the minor ducts, and that is going to end up into a lobule. So this terminal duct along with the lobule, this is going to be called as what is called as TDLU. It is going to be the functional unit of the breast, wherein there is going to be the actual physiology running of the breast. So that is called as a terminal duct lobular unit, basic functional unit of the breast, which is a terminal ductule with the acini of the lobule. The origin of most of the breast pathology is always from here. So it might be an origination of benign or malignant diseases which always takes place from here. So then comes the next thing, which is going to be the ligament of the Cooper. So you know that the breast is attached to the posterior wall. The breast skin is surrounded to the posterior wall with the help of the ligaments. These ligaments are called as the ligament of the Cooper. So what are the ligaments of the Cooper? Very much important. So these suspensory ligament of the Cooper, whenever there is going to be a tumor here, it is going to cause intense fibrosis. There is going to be a desmoplastic and inflammatory reaction, and that reaction is going to cause the skin puckering. So skin puckering is not at all something which is going to be related to a malignancy. So skin puckering, what you can say, it is not going to be a sign that it is going to be an involvement of a skin malignancy, because the ligament of Cooper are getting attached. The nipple areola complex, you both know it is the circular smooth muscles. So there are two muscles which are going to be present there. So radial smooth muscles and the circular smooth muscles. So the circular smooth muscles are going to contract, and the radial might contract, and it is going to cause the nipple erection. So these are divided into circular and radial fibers, circumferential retraction, and malignancy sites. So always remember that whenever there is going to be a malignancy, whenever the ducts are going to be involved, there can be pulling up of the nipple. So that pulling of the nipple is going to cause two retractions, which can be slit like, or it can be a circumferential retraction. So circumferential retraction more points down towards a malignancy, and a slit like more points down towards mastitis. So that is very much important for you to know. Montgomery tubercles. So to lubricate the nipple areola complex, there are going to be small glands. These are the sebaceous glands or the areolar glands, which are 8 to 20 per areola, and these are going to become more prominent during pregnancy. Why? Because they are going to lubricate the nipple and areola to prevent the cracking and fissuring, because the mother is going to secrete the milk. So to prevent the cracking and fissuring, these Montgomery tubercles are going to work hard. So surgical extent. So always remember, this is very important point. So what is the breast is going to extend from the second to sixth ribs. So second rib to the sixth rib, and from the sternum to the anterior axillary line. And always remember that something which is going to go beyond that is going to be the tail of Spence. So it defines the mastectomy boundaries. The axillary tail of Spence is always an important predictor during a malignancy resection. So never miss out that when you are going to go for a mastectomy. So there is an important plane. So what is a prepectoral plane? The prepectoral plane is the plane between the pectoralis muscle, the pectoralis fascia, and the breast. So let's consider a diagram. So let's draw a small diagram so that you will get to know what I am trying to say. So this is going to be our pectoralis major muscle. This is going to be the pectoralis major muscle. Over that there is going to be a prepectoral fascia. So this is going to be a prepectoral fascia, and over that there is going to be the breast tissue. Over that is going to be the breast tissue. So this is the breast tissue which contains the fat. So whenever the resection margin is from the prepectoral fascia, so first of all let's label it. So this black color is going to be the prepectoral fascia. This is going to be the pectoralis muscle. This is the pectoralis major muscle, and this is going to be the breast. So whenever you are going to operate any patient, so a simple mastectomy, whenever you are going to go for a simple mastectomy, you are going to preserve this prepectoral fascia. This prepectoral fascia is going to be preserved, and you are going to operate outside the prepectoral fascia. But when you are going to go for a modified radical mastectomy, whenever you are going to go for a mastectomy for any malignant disease, that is the time when your plane of dissection is going to land up into this region. So whenever you are going to go for a malignancy mastectomy, so this region is going to be, this plane is going to be your plane for surgical resection. But whenever you are going to go for mastectomy for benign disorders, any benign disorders you are going to go for mastectomy, may it be a phyllodes tumor or something else, so you have to go into this plane which is going to be anterior to the prepectoral fascia. So prepectoral plane between the breast and the pectoralis major muscle, that is the fascia. So prepectoralis muscle fascia, anterior mammillary fascia. So where is the breast fascia is going to fuse with this fascia. So that is going to be the plane for subcutaneous mastectomy. So in case of subcutaneous mastectomy, in cases of non-radical resections, you are going to go in this plane. So here this photo is when the prepectoral fascia is removed over it. So ideally whenever the prepectoral fascia is going to be present over it, it is going to be present like this. So this prepectoral fascia, if you can see, which I am coloring in the highlighter, so this prepectoral fascia you are going to also take out during the time of tumor excision, and whenever you are going to take it out during the time of tumor excision, this is the way you are going to see it. So this is the way you are going to see it. So this is when the muscle is bared, and the muscle is bare after the radical resection, and this is obviously what is seen is the axilla. So here what you can see, this is going to be the axilla. So this is the axillary dissection. We are going to talk about it sometime later. So what is the axillary dissection? Before going here, so these are the nodes which are present right now in the axilla. What is the boundary? If you can see here, this is the axillary vein. Very much nicely seen. So this is the axillary vein. This is going to be the long thoracic nerve. Here you can rightly see the long thoracic nerve. So here you can see the boundaries of axillary dissection. This is going to be the axillary vein. This is going to be the axillary vein. Beyond that is going to be the axillary artery. So this is the artery. The below is going to be the vein. If you can see here, this is going to be the long thoracic nerve. Never bear the long thoracic nerve. The long thoracic nerve is always to be kept in its sheath. Always and always remember. Here in posteriorly you can see that this is going to be the latissimus dorsi muscle, over which there are going to be the obviously there are going to be the lymph nodes present. And here you can see that this is going to be the thoracodorsal bundle. This is the thoracodorsal bundle between which all the lymph nodes need to be cleared. So this is the basic axilla. So this is the basic axilla, and here below you can see the angular veins. So whenever these angular veins are going to lie more superiorly, your extent of resection is going to reduce. So never go beyond the angular vein. So this is going to be the resection of the axilla when you are going to operate the patient of MRM. So level 1 lymph nodes. So always remember, the clinical division of the lymph nodes are different, and the anatomical stations are different. The anatomical stations are going to divide the lymph nodes into anterior, posterior, lateral, medial and apical, central. So we are not going to use it when we are going to operate the patient. What is the lymph node which you are going to use? So this is going to be the pectoralis minor muscle. So this is the pectoralis minor muscle. So it is going to divide, the axillary vein is going to be divided between the medial, posterior and the lateral compartment. So the lateral compartment, which is predominantly draining the breast, is going to be level 1. Behind the pectoralis minor is going to be level 2, and medial to the pectoralis minor is going to be the level 3 lymph nodes. Always remember that level 3 lymph nodes, the level 3 axillary lymph nodes always are going to drain the lymphatics from the arm as well. So nowadays the modified mastectomy which we are going to use, wherein we are going to retract the posterior, we are going to retract the pectoralis minor muscle. We are only going to remove the lymph node stations, lymph node 1 and lymph node 2. We are going to preserve lymph node 3. Why? Because they found out that it adds to morbidity by causing lymphedema. So never and never go for lymph node 3 dissection. So this is what is called as an Auchincloss modification for modified radical mastectomy. So remove level 1, level 2, don't cut the pectoralis minor muscle, and preserve the level 3 in order to prevent the morbidities associated with the arm. Very much important for you to know. This is going to be level 1 bilateral. This is going to be include the anterior and posterior. So it is important if you are answering into a viva, but just you should know that which lymph nodes lie where. Level 2 is the central. These are the central group of the lymph nodes and the interpectoral group. So interpectoral means the pectoralis major muscle, behind that is the minor muscle. Between those muscles there is going to be the lymph node, which is Rotter's group of lymph nodes. It is going to be level 2, which is going to be the central. Level 3 is going to be the apical. Level 3 means medial and superior to the medial border of pectoralis minor. So pectoralis minor के जो medial border है, that is going to be considered to be level 3 lymph nodes. Apical, and these are going to be the infraclavicular lymph nodes. What are the interpectoral lymph nodes? These are going to be between the major and the minor, clinically important because during axillary dissection you should always remove these lymph nodes. They harbor the subclinical disease, and therefore you might miss out the disease. Internal mammary nodes, so it is going to lie along the internal mammillary vessel, along the first and third intercostal spaces. It is the tumor. It is also the what you can say, it is the place where the tumor is also going to drain. So here you can see that the lymph nodes are along the internal mammary vessels. So these lymph nodes are going to harbor the tumor, which is going to be on the medial side of the breast. Very much important for you to know. Subcapsular nodes are the posterior group of the nodes which are going to drain the posterior chest wall and the subscapular region. So I hope it is crystal clear to you. Now talking about the blood supply. So always remember that the arterial supply to the breast is going to be an internal mammary artery of 60%, lateral thoracic artery, and thoracoacromial artery. So we know that thoracoacromial artery is a branch of dash part of axillary artery. If anybody can put in the comment section, I'll be more than happy to check it. So thoracoacromial artery, which is a branch of axillary artery, is going to supply the breast. Maximum blood supply comes from the internal thoracic or the internal mammary artery. So what is that clinical importance? So whenever you can, if that artery is being asked for a short note, so if internal mammary artery is asked for a short note, what are the things you should remember? So clinical pointers, the first thing which you are going to remember, it is going to be whenever the lady is going to be lactating, there you can hear what is called as a mammary souffle. So mammary souffle can be heard whenever the mother is going to be lactating. That is the first clinical pointer. Second clinical pointer, it is going to be a source of collateral circulation because the internal mammary artery is going to continue as a superior epigastric artery and going to anastomose with the inferior epigastric artery. So it is going to be a source of collateral supply. The third important point is this artery is going to be used for the coronary bypass surgery, which has excellent patency rates of almost 70 to 80% by the end of 10 years. So we are going to talk about it when we talk CVTS, but these are the few clinical pointers which you should know about this internal mammary artery. The venous drainage, the axillary vein, internal mammary vein, intercostal vein, and azygous vein. So similarly, you can see the blood supply in this diagram. So it is going to be the internal thoracic artery, thoracoacromial artery, and the lateral thoracic artery. So these arteries are going to be branches of axillary artery. From lateral, there is going to be subscapular artery branches, and this is going to be the internal mammary artery, which is going to supply the breast 60% of the time. So 60% supply is going to come from this artery. Lymphatic drainage, 75% to the axillary nodes, 25% to the internal mammary nodes, and cross drainage might also be present. So most of the times the medial tumors might metastasize to contralateral side. So many times there might be cross metastasis, which is very much important for you to know. So now comes the part which is going to be an investigation. So if in a surgery OPD, as we talked in thyroid, any patient is going to come to us with the swelling of thyroid. Similarly, the patient of breast is going to come to us with a lump in breast. Maximum number of times she is going to come to us with lump in the breast. So what is the difference between swelling and a lump? So swelling is seen and lump is felt. So these are the two things. So lump is always felt. So whenever you can see the protuberance over the body, it is considered to be a swelling. Whenever there is no protuberance, but when you palpate, you can feel a swelling, or you can feel something that is called as a lump. So lump and swelling, very important clinical distinguish point when you are answering in your vivas. Now we are going to talk about what is important. So how you are going to manage any patient of breast pathology. So any breast pathology, may it be breast pain, may it be nipple discharge, may it be nipple retraction, any patient of the breast comes to you, there is going to be a pro forma which is called as a triple assessment. So any breast disorder comes to you, you are going to follow the standard of triple assessment of the breast. What is the triple assessment? First we are going to talk about, जैसे हमने BLS बोला था, endocrine का any problem है, first is going to be the biochemical diagnosis, second is the localization, and third you are going to go is the stabilization, and after that operation. So वैसे ही इधर तीन approaches है, that is going to be triple assessment. The first thing you are going to do, yes, you are going to go for a clinical assessment, history and thorough examination, look for skin changes, nipple discharge, and lymphadenopathy. Second important thing is the imaging, first line investigation. Whenever the lady is less than 40 years of age, the breast is going to be dense, and that is the time when the mammography is going to contradict. So mammography cannot tell you the lesions. जैसे age बढ़ता जाएगा, वैसे जो TDLU है, the patient's breast tissue, the main functional unit is going to regress and it is going to be replaced by fat. So more fatty the breast, more is the outcome of the mammography. So imaging, ultrasound is the first line management when it's going to be a lady which is less than 40 years of age. After 40 years of age, you are going to go for a mammography. Many times this criteria might change to 35 or 30 depending on the institutes. Standard book mein diya hai 40 years, so we are going to remember 40 years. Then we are going to, if there is going to be any lesion, then we might consider doing an FNAC or a biopsy. So always remember, your clinical suspicion is going to point you out. Sir, कौन सा better है, FNAC या biopsy? So always remember, FNAC versus biopsy is a very big debate. क्लिनिकली क्या बोलते हैं कि FNAC अगर करोगे तो एक तो रिजल्ट सेम डे आएगा, but it is going to only and only tell about the cells. So whenever you are going to talk about FNAC, it is only and only going to tell you about the cells. It is not going to tell you about the tissue architecture. So whenever you are going to talk about it, you should consider doing a whatever. So whenever the cosmesis is going to be a problem, then you should consider FNAC. But अगर तुम्हें पता है कि यार this looks malignant, ये patient old age है, उसका already इतने सारे complications जा चुके हैं, patient को already she is giving the family history of breast cancer, so then at that moment of time there is no point in doing what is called as FNAC, because FNAC is only going to tell me about the cells and not about the tissue architecture. So वापिस FNAC करो, उसमें malignant cells आएंगे, उसके बाद biopsy करो. So clinical acumen is very much important. So what is important here? So clinical acumen is important. So let's talk about FNAC. So FNAC कब करोगे? Cosmesis जहाँ पे important है, young female है, fibroadenoma जैसा disease तुम suspect कर रहे हो, so we have to prove it on the tissue diagnosis. So उसके लिए अगर you are suspecting a benign lesion, basically अगर patients तुम देखोगे, if you have seen 100 breast patients, you can categorize that okay, this might fall under malignancy, this might fall under benign disorder. तो वो clinical acumen use करो, जहाँ पे benign disorder की possibility ज़्यादा लग रही है, वहाँ पे FNAC करो. But if you are thinking in terms of malignancy, always and always biopsy is going to be the first investigation of choice. तो biopsy करने के लिए always remember there are two gold standard things. Breast के लिए 14 gauge needle and axilla के लिए you are going to use 18 gauge needle. आगे मैंने notes में दिया हुआ है 14 gauge needle for the breast and 18 gauge needle for the axilla. Very much important. All three benign or malignant. So accuracy, ये तीनों चीज करोगे तो then your accuracy is always going to go towards 100%. So this is always you should be remembering. Sir, MRI का क्या role है? MRI आपने लिखा है, what is the role? So MRI is typically an investigation of tool for screening. आउटसाइड कंट्रीज में अगर फैमिली हिस्ट्री ऑफ ब्रेस्ट कैंसर है, हाई रिस्क फीमेल लग रही है, तो फ्रॉम द एज ऑफ 25 इयर्स शी इज गोइंग टू गेट अ 3 ईयरली एमआरआई डन. सो 3 ईयरली अगर एमआरआई करोगे तो एमआरआई इज गोइंग टू पिक अप द सब क्लिनिकल लीजन्स, बिकॉज मैमोग्राफी नहीं कर सकते. यूएसजी में छोटे छोटे लीजन्स स्किप हो सकते हैं, माइक्रो कैल्सिफिकेशंस, माइक्रो ट्यूमर्स कैन बी मिस्ड ऑन अ यूएसजी. सो दैट इज द टाइम व्हेन यू आर गोइंग टू सस्पेक्ट दिस लेडी टू एमआरआई. सो हाई रिस्क पेशेंट एमआरआई. और कहां पे एमआरआई यूज करोगे? प्रेगनेंसी है, यू आर गोइंग टू डायग्नोस, यू कैन नॉट यूज मैमोग्राफी, गो फॉर एमआरआई. थर्ड कहां यूज कर सकते हो? After doing a breast surgery, if there is a recurrence of the disease, so no role of CT scan there, because scar is also going to be a fibro scar, it is also going to appear hyperintense, and also the tumor is going to appear hyperintense. So no role of what you can say, no role of I'm so sorry. So there is no role of your mammography after you are going to operate the patient. So after operation, if there is a scar recurrence, you are going to go for MRI. So I hope these things are going to be crystal clear. So ये अगर चीज तुम्हें पता है, so now we are going to have a discordant triple assessment. So your clinical acumen is telling about something, it is malignant, but the patient, the report is FNAC is going to be a benign disorder. It might happen that the patient's FNAC might tell that this is going to be a benign disorder, but whenever you are going to actually go for your whenever you are going to go for a biopsy, there you can actually see that, so then biopsy is going to be an indicative for a malignancy. So whenever there is a discordant, disproportionate things going on in your mind, so what do you mean कि अरे clinically तो मुझे malignancy लग रहा है, but FNAC में तो अरे benign आया है. So that time the discordant imaging can be tackled with when you are going to do a biopsy of the breast. So very much important for you to know. So अब imaging modalities अगर short में हम लोग देखेंगे तो all imaging modalities. So as we talked earlier, ultrasound is less than 40 years, targeted assessment of the palpable lump or abscess, and node assessment is very much important. It is best for solid versus cystic differentiation. Axillary USG gives a subclinical nodal status. So whenever you are not having any axilla palpable, so you can go for an axillary USG which can tell you about the axillary nodes. Mammography usually more than 40 years, screening calcifications, obviously it is going to pick it up. It has two views, which is craniocaudal and mediolateral oblique. 1 milligray is what you are going to be the radiation of the is going to be 1 milligray, and it is better for microcalcifications, and this is going to give rise to what is called as a Bairad's classification. सो बायरैड्स, बायरैड्स क्या है, तो वी नो द बायरैड स्कोर, सो इट इज अ इमेज रिलेटेड स्कोर। जैसे हमने टायरैड्स में देखा था वैसे ही बायरैड्स है। तो बायरैड्स में क्या है, 1 2 3 4 5 एंड 6। सो 1 is non where you cannot comment, 2 is going to be benign, 3 is probably benign, 4 is probably malignant, 5 is looking malignant and 6 is biopsy proven disease. So why 6 दिया उन्होंने? Because many times the patient is going to have a diagnosis, she is going to undergo a neoadjuvant chemotherapy for the disease and then repeat mammography करेंगे, तो तब बायरैड 6 का रिपोर्ट देगा। So whenever बायरैड 6 का रिपोर्ट तुम्हारे हाथ में आता है तो always ask the patient, have you had any treatment before? If she says yes, then it means that she is a post neoadjuvant chemotherapy patient. So history is very much important. The investigations which are going to come to you are also going to be very important. Sir, MRI कब करोगे? Obviously, if there is going to be a family history, if there is going to be a family history of breast cancer, it has highest sensitivity in picking up the lesions, and you may use the gadolinium contrast. But it is not for routine screening. Can overestimate the disease, so no radiation, and it has also no radiation exposure. So whenever a patient is going to come to you, कितना भी affording है, कितना भी पैसे वाली है, तो भी MRI सबको prescribe नहीं करने का, because it can over diagnose the disease. हमें over diagnosis कब चाहिए? अगर syndrome है तो हमें पता है कि this patient might have a malignancy, so over diagnosis is important there. Normal patient में over diagnose करके क्या मिलेगा? सबके mastectomy कर दोगे, क्या what is going to happen? So don't do this. पेट स्कैन अगर देखोगे तो इन लोकली एडवांस डिसऑर्डर्स और रूटीन पेट स्कैन इज नॉट इंडिकेटेड। अगर पेशेंट का तुमने देखा वर्कअप बेसिक करवाया, इफ बेसिक वर्कअप ओनली देयर इज गोइंग टू बी अ ब्रेस्ट लंप, एक्सिला इज क्लिनिकली नेगेटिव, पेशेंट के बेसिक वर्कअप चेस्ट एक्सरे, योर व्हाट यू कैन से द एक्सरे ऑफ द ब्रेन, इफ देयर आर गोइंग यू आर गोइंग टू डू लंबार एक्सरेज, दीस आर गोइंग टू बी नॉर्मल बिकॉज मैक्सिमम अमाउंट ऑफ टाइम द मेटास्टेसिस गोज टू योर spine. The second most common metastasis might be lung or liver. Brain mets are also common, but always remember that CT does not pick up the brain mets. So CT scan does not pick up the brain mets. For brain mets, ideal investigation is always MRI. क्योंकि छोटे छोटे मेटास्टेसिस सीटी में मिस होने वाले हैं, इवन दे माइट नॉट पिक अप द कॉन्ट्रास्ट, सो सीटी ब्रेन मेट्स के लिए सीटी स्कैन इज नॉट यूजफुल। तो इसलिए अगर लोकली एडवांस डिसीज है, यू नो दैट लिम्फ नोड्स आर पल्पेबल, एक बार लिम्फ नोड्स पल्पेट होने को लग गए तो इट इज अ लोकली एडवांस डिसीज। सो ब्रेस्ट लंप विथ लिम्फ नोड्स, go for a PET scan. No lymph nodes clinically, breast का disorder छोटा है, early breast cancer, we are going to talk about it. So that is the time when you need not go for a routine PET scan, just the USG and lumbar x-rays are more than enough. So PET scan in locally advanced disease or staging metastasis, it is an expensive disorder and false positives because patient को कहीं पे अगर infective focus भी रहेगा, skull में छोटा folliculitis रहेगा तो भी it might show up as a metastasis. So don't go for unnecessary investigations. Ductography might be done. Ductography कब use करेंगे? अगर duct ectasia है, bloody nipple discharge है, एक ही duct में कुछ issue है, तो you are going to go for it. Tomosynthesis, so this is going to be a 3D mammography which has come. So whenever these are going to be the dense breasts, so normally हमने देखा दो व्यूज रहते हैं, क्रेनियोकॉर्डल एंड मीडियोलैटरल ऑब्लिक, so दो व्यूज are normally present, but when you are talking about this 3D breast construction, this is going to be one useful in the dense breast, so it reduces the recall rate and it is a new imaging remodeling investigation. So आजकल हम बोर्ड भी देखने लगे हैं, breast cancer screening program, we have 3D mammography. So what is that 3D mammography? It is nothing but it is going to be more useful in the dense breast, so very much important. So what is the biopsy technique? So core needle biopsy, 14 gauge for the breast lesion and 18 gauge for the lymph nodes. So whenever you are going to go for biopsy of the breast, always remember 14 gauge needle for breast and 18 gauge needle for the lymph nodes, and minimum 4 biopsies are going to be there which are going to give a good histological yield, and it is always preferred over FNAC whenever you are clinical acumen. So clinically अगर आपको लग रहा है कि this is more pointing towards malignancy, high risk of family history, you are going to go for a biopsy straight away. FNAC में time waste मत करो. Then there is going to be a vacuum assisted biopsy. A vacuum assisted biopsy can be done within 8 gauge or 18 gauge needle. So it has a vacuum attached to it. Normally क्या होता है, core biopsy में you are going to just take the tissue after firing, but अगर vacuum attach करोगे तो ज्यादा तुम्हारे पास टिश्यू का ट्यूमर बर्डन आएगा. So छोटे छोटे जो लीजन्स है 1 सेंटीमीटर के, those can actually भी पूरा के पूरा निकाल सकते हैं तुम vacuum assisted biopsy से. So it can be used for impalpable lesions as well. So छोटे lesions, normally routine mammography में कुछ lesion मुझे spot हो गया तो क्या करने का, तो then you can go for this vacuum assisted biopsy because these are the small lesions, पूरा का पूरा biopsy ही हो जाएगा, and that is going to give rise to a diagnosis as well. FNAC, it is a fine needle aspiration cytology. So cytology मतलब cells का architecture मिलेगा, it is quick, cheap and gives cytology only, no cellular architecture. It cannot distinguish the invasive from a non-invasive disorder. Excision biopsy, it is reserved for the lesions which are not amenable for core biopsy after localization. So क्या होता है, many times even after localizing the disease, the biopsy comes persistently negative. So whenever you are going to have a disorder in the breast, which you might feel that अरे इसमें कुछ गड़बड़ है, patient की family history है, but patient को radiologically भी कुछ problem लग रहा है, तो that is the time when you are going to clip the disease and you are going to go for a excision. So पूरा का पूरा tumor निकाल के biopsy के लिए भेज दो. that is the excisional biopsy. And sentinel lymph node biopsy, we have talked about it a lot when we discussed about melanoma. Though you dye use करेंगे double dye technique, technetium 99 and patent blue dye. Now one comes the important thing, because breast disease might see in the pregnancy, so blue dye is contraindicated in pregnancy. So pregnancy में blue dye is contraindicated. So always remember, we are going to talk about it when we are going to talk about the blue dye and the breast cancer in pregnancy, but it is going to be contraindicated in pregnancy. So single dye technique is used in only pregnancy. So अगर MCQ आया, or if an MCQ comes कि अरे normally the breast cancers sentinel lymph node biopsy is done with a double dye technique. But whenever this patient is going to come to you with a pregnancy, what is going to be your line of management? What is going to be your line of management? So what was the question? A 28-year-old female who is diagnosed as a breast cancer to you has to undergo a surgery, and she is 28 weeks pregnant, and this patient is going to undergo sentinel lymph node biopsy for a clinical negative axilla. So in this patient, what will be the modification of SLNB? Option 1 is going to be, I am going to keep everything same, use both the dyes. The second thing, I am going to eliminate patent blue, I am going to eliminate technetium 99, or I am not going to do an axillary dissection at all. So yes, your option is going to be eliminate the patent blue, and you are going to only and only use the technetium 99 scan, because technetium 99 in the low doses is safe whenever the fetus is there. Patent blue को eliminate क्यों करने का? No carcinogenic properties. It has high risk of anaphylaxis in pregnancy. So patent blue is to be eliminated while doing sentinel lymph node biopsy in a clinically node negative female who is a pregnant female. I hope it is crystal clear. So now we are going to talk about the benign breast disorders. So after completing the basic investigations of the breast, now we are going to talk about the benign breast disorders. Sir, benign breast disorders में क्या important है? So always remember that this is Andy. What is Andy? My name is Anand. So is it Andy? No, my name is ANDY. This is ANDI. So it is aberrations of normal development and involution. So breast का problem क्या है? I am going to tell you. So whenever the lady is going to have menses, on the basis of estrogen, progesterone, the lobules go, the lobules are going to increase in size, again decrease in size, increase in size, again decrease in size. So because of this rapid turnover of the lobule involution and evolution, that is the reason when because of that recurrent wear and tear, the patient is going to have some disorders. So patient might have a normal breast, from that it might go to something called as aberration, from there is a pathology. So that aberration might not always be a pathology. So this is the first thing you are going to fit in your mind. So phase 1, whenever the child is going to grow, so whenever that girl is going to grow, she is going to have development of the breast. So during the development of the breast क्या गड़बड़ हो सकता है? So there is a fibroadenoma. So development के time पे अगर गड़बड़ हो गया, तो there is going to be a fibroadenoma, because the lobules are not going to be formed, or the stroma is not going to be formed. Phase 2 में क्या होता है? लेडी को there is going to be again and again the cyclical changes. So वो cyclical changes के वजह से wear and tear, degeneration and regeneration के इसमें patient को क्या होने वाला है? There is going to be a cyclical mastalgia, and the patient might have the nodular breast. So we are going to talk about nodular breast in a time. Phase 3 is involution. So normally क्या होता है? After the age of 40, 45, 50, there is going to be menopause, and there that breast is going to involute. But अगर वो involution के time पे degeneration हो गया, तो there is going to be formation of the cyst. So microcyst and macrocyst. And what can happen during that involution? If there is inflammation in the breast, there can be what is called as sclerosing adenosis or duct ectasia. Because क्या होगा? बाहर के region में अगर inflammation होगा, typically seen in female patients who are smokers. So what is going to happen when the female is going to smoke? There is going to be small amount of inflammation all around, and that inflammation is going to pull the duct outwards, and that is going to cause the ectatic duct segments. So this is going to be very much important when you are dealing with the phase 3. So after 35 to 40, 55 years, this is going to be the disease present here. So hyperplasia of the ducts, there might be atypical ductal hyperplasia or atypical lobular hyperplasia. So what happens is normally the duct is going to be lined by a single cell. So single layer of cells normal duct में रहने वाला है, but whenever there is going to be a hyperplasia, there is going to be multiple cells which are going to be lined. So this is going to be atypical cellular hyperplasia. And DCIS and LCIS क्या है? तो whenever it is in situ, so always remember, whenever any type of the duct pathology increases to more than 2 mm, it crosses from aberration to true pathology. So whenever you are going to see a small lesion in the breast, you are going to take a biopsy, and there it is going to come as a duct DCIS. So DCIS, you are going to again talk about it. DCIS is always going to be more riskier. So the risk of malignancy is going to increase 5 times. So hence you are going to go for excision. So DCIS को breast में कभी नहीं रखने का. LCIS you can keep it in the breast. LCIS को कोई problem नहीं है. LCIS पहले प्रिय malignant बोलते थे. What is in situ? So अभी तक वो malignant change आया हुआ है, but it has still yet not breach the basement membrane. So it is in situ carcinoma. So whenever it is a DCIS, you have to go for excision. LCIS ko you can preserve. So golden rule. Now we are going to come to the first disease, which is going to be a breast pain, which is mastalgia. अगर ब्रेस्ट पेन की पेशेंट अपने ओपीडी में आएगी, so what are the things you are going to ask? The first thing is, if it is cyclical? So cyclical है मतलब it is going to, yes, it begins around the day 14 of ovulation. It is going to go on increasing by the time the patient is going to be ovulating and after the ovulation, and it is going to resolve with the menses. So menses resolution के time पे वो भी resolve होने वाला है. So this is a cyclical mastalgia, typically seen in the reproductive age, and it is bilateral, diffuse with heavy and tender breasts. But whenever there is going to be a non-cyclical mastalgia, there is no relationship with it. It is usually in the pre and perimenopausal females, and typically it might be associated with burning or sharp pain. So it might have a trigger point. What is the trigger point? These old females might develop what is called as a fibromyalgia, and there might be this costochondritis. So it might originate actually from the costochondral junction, which might be falsely picked up as a breast pain. So first rule out the costochondritis. Then the other thing which is important might be a periductal mastitis. What happens is, we already saw that due to smoking female, due to inflammation going on in the body, there might be periductal inflammation. So there might be periductal mastitis. Also it might be referred from the cervical spine. So we know that the cervical spine or the back pain might radiate to the breast anteriorly, and it might cause a false sensation of the breast pain. So whenever a non-cyclical mastalgia patient comes to you, first rule out these other causes which might cause a breast pain. Similarly, when we are talking about cyclical mastalgia, there is no trigger point to it. It is estrogen and progesterone imbalance and essential fatty acids deficiency. So here you are going to give what is called as essential fatty acids. So वो जो evening primose oil वगैरह देते हैं, so basically these are the essential fatty acids which are going to reduce the inflammation. So whenever the non-essential fatty acids increase in the body, we know that it is a condition of inflammation, and that inflammation is going to trigger this. So whenever you come across a cyclical mastalgia pain, you are going to give up essential fatty acids. So evening primose oil with flaxseed oil, it is the first line because the essential fatty acids are going to reduce the inflammation. And danazol might be used. So second line treatment comes the hormonal treatment. It has side effects, or tamoxifen can also be used. So ormeloxifene, which we know that Saheli tablet, then it might be a tamoxifen. So these are the drugs which are second line. But pehle line agent mein, first to reduce the inflammation, if the breasts are going to be large, then you can give them the under support garments, you can give them proper support. If the breasts, the pain is not resolved with the conservative management like essential fatty acids, then you can add on to the hormonal therapy. And here whatever is there, if the trigger point is there, if you see that, okay, this is the point where there is going to be costochondritis, so here you can straight away go for an injection of hydrocortisone with local anesthetic. So it is going to reduce the local inflammation and reduce the breast pain. And NSAIDs can also be used to treat the underlying cause. If there is going to be cervical pain, slip disc, if there is going to be a problem with the spine, so you are going to treat it primarily. Very much important for you to know. So pain scoring, record pain for 1 month using a breast pain chart. So whenever the patient is not knowing about the pain, sir मुझे नहीं पता वो menses के साथ मैंने उतना correlate नहीं किया, so then that is the time you can give her a breast pain chart. So you can just ask her to come after 1 month. So if it is very acute, the pain is very acute, like something like abscess or something like that, then obviously you are going to evaluate and admit. But if you think that this pain is non-specific, you are not able to localize any pathology, so you can give her a breast pain chart. That chart comes with 28 days of the breast pain, and she has to grade the she has to grade the pain of from 1 to 10, how is the pain. So you can see, okay, the pain is in the second half of the cycle, the pain is not significant to the any cycle. So here you can diagnose the cyclical or non-cyclical mastalgia. And this Cardiff-Lucknow nodularity index. So whenever you are going to check the nodularity of the breast, because the patients of whenever in the reproductive age group, because of constant wear and tear, the females are going to have what is called as a nodular breast. So there comes what is the Cardiff-Lucknow nodularity index. So what is Cardiff-Lucknow nodularity index? It is an Indian-based surgeon who actually defined about the nodularity of the breast. And here, what happens is the pain might be reduced with that evening flaxseed oil and primose oil. But for the nodularity to go off, that nodular breast always needs ormeloxifene or other selective estrogen receptor modulators. So always remember these two things: the Cardiff-Lucknow nodularity index, 1 being the least nodular and 4 being the most nodular breast. And for treatment, you should give ormeloxifene or other SERMs like tamoxifen to the patient, and it is going to reduce the nodularity of the breast as well. So it is very much important for you to know. Then what is evanescent lump? The lump that appears and disappears spontaneously within the cycle, and it usually represents a prominent lobule or a cyst and may be associated with inflammation or localized pain. So what is evanescent lump? So whenever we see that evanescent lump, it means that the lump is coming and going. So patient एक बार आई, okay, lump दिखा, अगली बार आई तो lump गायब हो गया. So it is related with the cyclical growing and outgrowing of the breast. So it is very much important. It might be a single lobule hypertrophy sometimes, so it might go on its own. So now we are going to talk about the breast cysts. तो पहले हमने देखा कि पेशेंट को साइक्लिकल mastalgia है तो क्या करने का. Now talking about the breast cysts. So what are we going to talk here? Important thing is BIRADS 2. So कोई भी अगर breast cyst है तो you are going to go. It is obviously seen in the postmenopausal female. So normally female का age group more than 40 रहेगा. So your investigation of choice is always and always going to be yes mammography. So mammography करने के बाद में BIRADS रिपोर्ट आ गया. तो BIRADS रिपोर्ट 2 सिंपल सिस्ट कुछ मत करो. You can just aspirate if it is causing pain. You can just do an aspiration. That is all. So reassurance, aspiration only if symptomatic or tense or patient is having cosmetic issues. Agar BIRADS 3 it is a complicated cyst, it contains fine internal echoes. It might be a cholesterol crystals. So you are going to go for a short interval follow up. और antibiotic trial दे सकते हो if it looks inflammatory. अगर कॉम्प्लेक्स सिस्ट है, कॉम्प्लेक्स सिस्ट मतलब अगर सॉलिड कंपोनेंट आ गया तो इट बिकम्स अ कॉम्प्लेक्स सिस्ट. इन थायराइड आल्सो वी सॉ एनी सॉलिड कंपोनेंट इज गोइंग टू बी अ प्रॉब्लमेटिक. सो सॉलिड कंपोनेंट थिक सेप्ट है, सो यू आर गोइंग टू गो फॉर अ बायोप्सी ऑलवेज. कॉम्प्लेक्स सिस्ट है तो गैलेक्टोसील है तो एस्पिरेशन करो, इट माइट रिजॉल्व स्पॉन्टेनियसली. अगर द पेशेंट को कुछ प्रॉब्लम है तो यू कैन सप्रेस द लैक्टेशन ऑफ द पेशेंट. बट गैलेक्टोसील है तो एस्पिरेशन इज मैंडेटरी. सो गैलेक्टोसील है तो एस्पिरेट करो. सिंपल सिस्ट है तो यू कैन ऑब्जर्व. कॉम्प्लेक्स सिस्ट है तो एंटीबायोटिक देके फॉलो अप बुला. एंड इफ इट इज गोइंग टू सॉरी कॉम्प्लेक्स सिस्ट है विद सॉलिड इकोज सॉलिड कंपोनेंट देन बायोप्सी करो. एंड इफ इट इज गोइंग टू बी अ कॉम्प्लिकेटेड सिस्ट देन यू आर गोइंग टू गो फॉर व्हाट इज कॉल्ड एज एन एंटीबायोटिक फॉलो अप. So 3 most important parts: a simple cyst, complicated cyst, and a complex cyst. So simple cyst follow up, complicated cyst antibiotics and 6 monthly follow up, and complex cyst associated with solid nodules always and always go for a biopsy. Very much important for you to know at this stage. Fibroadenoma. So now the childhood. So when the breast is developing, then we are going to talk about the disease which is the fibroadenoma. So arises during the lobule development phase of 15 to 25 years, and it is a benign fibroproliferative disorders. 2 to 3 centimeters, smooth from mobile breast mouse. So basically it can go to any part of the breast and again come back. So that is why it is called as a breast mouse. So it has a relative risk of malignancy 1.5 times, and if the patient has a family history of breast cancer, then that chance of malignancy is going to increase to 4 times. So whenever a fibroadenoma patient is going to come to you in the OPD, the important thing which you are going to ask her that if you have a family history of breast cancer, then you are then your risk of malignancy is going to increase to the 4 times. So very much important. Multiple papillomas, so the relative risk is 3%. Management is observation for lesions. Why? Because till 25 years of age more fibroadenomas can form. After 25 years of age you can go for excision. Confirm by triple assessment. FNAC karo because you think that it is benign. FNAC is sufficient. Core biopsy if more than 25 years because fibroadenoma is less likely in 25 years of age. Indication of excision is size more than 3 centimeters, age more than 30, or patient is because having atypical features or rapid growth. So whenever age is more than 30, whenever the size is more than 3 centimeters, straight away go for surgery, don't think twice. But if it is less than 2 centimeters, chota lesion hai, young female hai, agar bas problem is with the pain, you can settle it with NSAIDs. If still not ready, she wants to get it removed, then yes, obviously you have to go for surgery. Giant fibroadenoma more than 5 centimeters, it is usually seen in the adolescents, rapid growth and excision is recommended. So any giant fibroadenoma more than 5 centimeters, you are going to remove it. Most take home point here, always remember that the relative risk of fibroadenoma, patients are going to ask you in the OPD what is the risk factor for development into malignancy. Normally a patient का malignant chance of getting a malignancy after fibroadenoma is 1.5 times. अगर उसको malignancy होनी है लाइफ में तो 1.5 times acceleration होगा. But if the patient is having familial history of breast cancer, then it is an ideal indication for excision because the risk is going to climb to 4% in patients of family history of breast cancer. I hope it is clear. फाइलोड्स ट्यूमर क्या है? तो फाइलोड्स ट्यूमर, कुछ लोग फाइलोड्स ट्यूमर को ही दे यूज्ड टू कंसीडर कि जायंट फाइब्रोएडेनोमा मतलब फाइलोड्स ट्यूमर. सो नो, फाइलोड्स ट्यूमर इज डिफरेंट, जायंट फाइब्रोएडेनोमा इज डिफरेंट. सो इट इज अ रेयर फाइब्रोएपिथेलियल ट्यूमर. वी सॉ दैट फाइब्रोएडेनोमा डेवलप्स फ्रॉम द लोब्यूल, बट दिस डेवलप्स फ्रॉम द स्ट्रोमा ऑफ द ब्रेस्ट. द फैट कंटेंट, द फाइब्रोफैटी टिश्यू, उससे होने वाला डिसऑर्डर इज गोइंग टू बी द फाइलोड्स ट्यूमर. प्रेजेंट्स एट रैपिडली ग्रोइंग मास, ओवरलाइंग स्किन कैन अल्सरेट. हिस्टोलॉजिकल क्लासिफिकेशंस अगर देखोगे तो it might be benign, borderline or malignant. We have already seen in the patients अगर माइटोसिस लेस देन 5 है, 5 to 9 है, और अगर मोर देन 10 है, सो इफ लेस देन 5 इट इज अ बिनाइन. सो इट इज अ हिस्टोलॉजिकल थिंग. सो व्हाट इज द हिस्टोलॉजिकल थिंग? इफ माइटोसिस आर गोइंग टू बी लेस देन 5 देन इट इज कंसिडर्ड अ बिनाइन. इफ इट इज बिटवीन 5 to 9 then it is considered to be intermediate, and more than 5 is 10 is going to be malignant. So infiltrated margin, stromal outgrowth, heterogeneous environment, तो ये सब चीजें you are going to see when the histopathologist is going to check it out. Malignant phyllodes, so always remember it is a stromal tumor, it is a sarcoma, it is not a carcinoma. So it is always and always going to metastasize with the help of a हेमाटोजेनस स्प्रेड, सो इसमें एक्सिलरी लिम्फ नोड का कोई बात ही नहीं आता. सो नो रोल ऑफ एक्सिलरी डिसेक्शन व्हेन यू आर गोइंग टू टॉक अबाउट द phyllodes tumor. So surgery is the wide local excision with 1 centimeter clear margin, and always remember that positive margin has high recurrence risk. So we are going to talk about the margins, how much at what places which margins are to be taken. So first thing we are going to talk about is the DCIS. So DCIS को excision करना है when you are going to excise 2 mm margin is required. Sir, when it is a CA breast, so CA breast अगर diagnosed है तो here you can go for a malignancy. So here you can go for an excision. Here you can go for an excision with no tumor at ink. Sorry. So here you can go for excision with no tumor at ink. CA breast है तो no tumor at ink. And if it is going to be a phyllodes, if it is going to be the phyllodes, then you are going to go for 2 centimeter margin. So this is going to be critical for you to know. Whenever you are excising a DCIS में 2 mm margin is important. Whenever you are excising a CA breast, the ideal margin is no tumor at ink. But whenever you are excising a phyllodes tumor, the ideal margin should be 2 centimeters. So 2 centimeters for phyllodes, 2 mm for DCIS, and CA breast में no tumor at the ink. So always remember, malignancy भी होगी तो breast का no tumor at ink is okay. DCIS despite being less malignant 2 mm is required, and phyllodes despite being majority times benign 2 centimeter margin is very much important when you are going to excise the phyllodes tumor. So I hope it is clear. Mastectomy for a massive tumor. So always remember, if the breast is small and the tumor is big, you cannot conserve the breast. You cannot just go for a lumpectomy. That time you are going to go for a mastectomy for the patient. A simple mastectomy. We saw that the mastectomy plane should be anterior to the prepectoral fascia. You are going to preserve the prepectoral fascia during a simple mastectomy. No role for neoadjuvant and chemotherapy. Malignant phyllodes may benefit for radiation. So मैं कहूँगा कि CA breast, when you are going to talk about CA breast, chemo is almost given to all patients except I'm going to tell you. So chemo सभी को देते हैं, radiation is optional. So radiation के कुछ criteria है, but when it's a phyllodes, there is no role for chemo, radiation is mandatory. So कौन से patient को क्या चाहिए वो जरूरी तुम्हें पता होना चाहिए. Just don't go for haphazard learning कि कोई भी tumor आया तो go for chemotherapy, go for radiotherapy, or refer him to a medical oncologist. So you are a surgeon, the patient is come with a trust with you to operate, you are going to cut the patient, so you should be knowing the guidelines as well. I am not expecting that you go and give the chemotherapy to the patient, but at least इसको chemotherapy लगेगा नहीं लगेगा, किसको radiation लगेगा नहीं लगेगा, इतना तो basic you should understand. Despite being a surgeon, that is the minimum basic requirement you should have. So what are the nipple disorders? Nipple disorders अगर हम बात करेंगे तो there are few nipple disorders. I'll just run through them. You are already familiar with them. Congenital nipple inversion है, present since birth है, no change. Only problem is during the time of lactation, the female might have problem with the breastfeeding. So manual eversion can be done, or a suction device. There is a suction device which you can apply, which is going to evert the nipple. Acquired nipple retraction अगर है because of mastitis, malignancy, so treat the underlying mastitis. And if the duct is causing a nipple, what you can say inversion, so वो specific duct तुम निकाल सकते हो, उसको बोलते हैं Hatfields duct excision. So even after mastitis is suppressed, but the duct is fibrosed and it is pulling the nipple inward, you can just cut that duct so that the nipple is going to invert back. Acquired nipple retraction, if it is circumferential, we saw that slit-like, it is benign. When it is circumferential, it is malignant. So it might be fibrosis or invasion of the lactiniferous ducts. So triple assessment always important. So whenever circumferential nipple retraction, go for a triple assessment. Any patient, you are obviously going to go for a triple assessment, but here triple assessment with underlying malignancy is important. Cracked nipple है तो lactation के वजह से, because of lactation there might be a cracked nipple. 48 hours breastfeeding को rest दे दो. We saw that Montgomery tubercles which are going to be there at the nipple areola complex are going to secrete the sebum which is going to lubricate the nipple and areola complex. If at all there is going to be a cracked or fissured nipple, wash it with the saline moisturizing cream or antibiotic cream. So that is more than enough. Nothing else is important. 48 hours breast feeding rest is important. अगर patient को nipple papilloma है, अगर nipple पे कोई inversion, nipple पे अगर कोई lesion आ गया, so this is the nipple and there is going to be a papilloma. So ये papilloma को excise मत करो. What you can do is you can simply ligate the papilloma at the base. So after ligating, the feeder vessel is going to stop and naturally the papilloma is going to slough off. So tie the base with the suture. There is avascular necrosis and it is going to slough off the papilla. अगर एक्जिमा है तो ऑलवेज रिमेंबर एक्जिमा वर्सेस पैजेट्स डिसीज माइट बी अ शॉर्ट नोट विच कैन बी आस्क्ड. एक्जिमा में क्या होता है? इट इज बिकॉज ऑफ द डर्मेटाइटिस. इट इज अ स्किन कंडीशन. बट व्हाट इज अ पैजेट्स डिसीज? पैजेट डिसीज में क्या होता है, वी नो दैट दिस इज द निपल एरियोला कॉम्प्लेक्स, दिस इज गोइंग टू बी द ओपनिंग ऑफ द डक्ट्स. सो मैलिग्नेंट सेल्स जो रहेंगे वो ये डक्ट से बाहर आने के बाद में स्किन को भी इन्वॉल्व करके पूरा स्किन को डिस्ट्रॉय करेंगे. सो द स्किन इज गोइंग टू बी डिस्ट्रॉयड. सो पैजेट डिसीज में अगर देखोगे तो डक्टल कार्सिनोमा इन सीटू और इन्वेसिव माइग्रेशन ऑफ द सेल्स कैन एक्चुअली कॉज डिस्ट्रक्शन. सो ऑलवेज रिमेंबर इट इज गोइंग टू कॉज डिस्ट्रक्शन. एंड एक्जिमा इज मोस्टली बायलैटरल. एक ब्रेस्ट पे एक्जिमा नहीं होगा, इट माइट बी बायलैटरल. सो एक्जिमा अगर है तो बीटामेथाजोन क्रीम देना है एंड यू आर गोइंग टू रिमूव द इरिटेंट व्हिच इज गोइंग टू कॉजिंग द एक्जिमा. इट इज लाइक अ एलर्जिक डिसीज. सो यू आर गोइंग टू रिमूव द कॉजेटिव एजेंट. पैजेट डिसीज है तो ऑब्वियसली द आर्किटेक्चर ऑफ द निपल इज ऑलमोस्ट गॉन. सो इट इज अ क्राइटेरिया फॉर अंडरलाइंग मैलिग्नेंसी ऑफ द ब्रेस्ट. सो यू हैव टू इवैल्यूएट द डिसीज. सो यूनिलैटरल एक्जिमा इज अ पैजेट्स until unless proved. So you have to go for what is called as a skin biopsy. We saw in dermatology that whenever a paget disease is there, a subcutaneous malignancy, a punch biopsy can be taken and wide local excision of nipple areola complex if it is going to be an invasive disorder. So it is important for you to know. So now we are going to talk about, yes, clinically evident nipple discharges. So nipple discharge कैसे कैसे हो सकता है. So if it is a single duct nipple discharge from one duct orifice, or it might be a multiple duct discharges. So single duct discharge unilateral from one orifice, it might be serous, clear, watery, and maybe because of intraductal pathology as well. So how is the breast malignancy going to have a nipple discharge? So the most common nipple discharge in a breast malignancy is always serous, not a bloody nipple discharge. Sir, bloody nipple discharge most commonly किस में दिखेगा? तो it might be seen in a duct papilloma. We are going to talk about it. अगर blood stained है तो most significant it is associating with papilloma or a DCIS. Always remember. अगर spontaneous है, ask for if it is a spontaneous nipple discharge or it is going to be an auto after an expression that nipple discharge comes. If bilateral multi-duct green or nipple discharge है तो it is a sign of duct ectasia which is going to be because of underlying inflammation. Mostly seen in smokers. And what is the treatment of choice? You are going to go for ciprofloxacin and metronidazole. So it is going to reduce the infection in the breast and reduce the inflammation as well. Purulent discharge है तो it might be periductal mastitis or abscess. And management more than 40 years है तो obviously you are going to remove that duct. Any 40 years bloody nipple discharge, that duct might have a papilloma or it might harbor a malignancy. Just go for duct excision, single duct excision or Hatfield's total duct excision if multiple ducts are involved. So what is Hatfield's duct excision? So if you are going to see the breast, this is going to be the nipple areola complex. These are going to be the multiple ducts which are opening inside the breast. So whenever you are going to remove the part of this, so this whole ducts are going to go. This is called as a Hadfield's cone excision. So cone के shape में तुम निकालोगे Hadfield's cone excision. While if you are a single duct has a pathology, so you can actually ligate the single duct, lift it up and एक duct निकालते निकालते जाके इधर तुम बांध सकते हो. So if a single duct is involved and removed, it is a single duct excision. But if you are going to go for a cone excision, that is going to be a Hadfield's cone excision. And galactorrhea अगर patient को है तो check for serum prolactin levels. If they are increased, the problem might be in the brain. We had already seen that pituitary adenoma, whenever it is associated with men's syndrome, whenever we saw men 1 syndrome, pituitary, parathyroid, pancreas. So that pituitary tumor which is going to be there, it is going to be mostly a functional tumor if it is secreting, and it is going to secrete a prolactin. The second most hormone is going to be the growth hormone. Very much important. So check the prolactin, exclude the other causes like what you can say, if the patient is taking any metoclopramide, any D2 agonist which might D2 antagonist which might cause hyperprolactinemia in the patient. So medical causes be rule out karo, do an MRI, see the pituitary cause, and then you are going to treat it accordingly. Breast infections. So all the breast disorders under one roof, obviously. So what are the breast infections? Lactational mastitis and abscess. So what is the cause? The cause is Staphylococcus aureus. So Staph aureus is the most common cause. Abscess is Staph aureus. Cellulitis, Streptococcus. We have already seen when we talked about general surgery. Entering through the cracked nipples occur in the first few weeks after lactation because what happens is the baby is going to bite. There might be some problem while the time of the weaning, and while the time of initiation, actually the baby and the mother's bonding is not that great, so that breastfeeding might not initiate properly. So that is the reason when the cracked or the fissured nipple will be a place from where the Staph aureus is going to enter. Clinical features are erythema, tenderness, fever, and USG is going to show some amount of cellulitis with floating debris which is an abscess. Medical treatment is cloxacillin because we have to use antibiotics very much cautiously because breastfeeding में baby को वो antibiotic जाके problem हो सकता है. So never you are going to use any drugs like ciprofloxacin. There is no use of ciprofloxacin in patients who are lactating when they are breastfeeding. Why? Because ciprofloxacin can cause what is called as early tendon rupture, cartilage disruption in the child, and be deadly. So never use antibiotics. Whenever prescribing antibiotics for a lactating female, always consult a pediatrician or always consult a gynecologist and ask them which antibiotics are essential if you don't know about them. Abscess management, initially all the abscess in the body are to be drained except a few. The few exception is going to be this abscess, wherein you are first going to go for a USG guided aspiration. Why? Because after removing that abscess and giving antibiotics, it might settle down. The problem is with the duct or with the lobule, so it might settle down, and repeat aspiration if needed. But if abscess is large, so more than 3 centimeters or more than 30 ml, sir same criteria मैंने brain में भी बोला था. So more than 1.5 centimeter midline shift or more than 5 mm midline shift with 30 ml of EDH. So अगर ये indications fulfilled है, so that is the time when you can actually go for a craniotomy for a patient. Similarly, more than 30 ml plus अगर है, तो suction drain insert करके रखो, so that all the as fluid is going to get sucked out and that cavity is going to collapse, and irrigate the cavity with 14 days antibiotic course. अगर फिर भी नहीं resolve हो रहा है तो then you can go for surgery, but surgery might cause very morbidity because it is going to cause a big scar. There might be a lot of fibrosis. So बाद में अगर malignancy भी हो तो समझेगा नहीं. So ideal thing क्या है? You can put a drain which is a suction drain and you can flush the antibiotics from the drain. Very much important for you to know. Non-lactational mastitis. So what is a periductal mastitis? It is an inflammatory, might be non-autoimmune process which is strongly associated with smoking. So इसके वजह से क्या होगा? पहले mastitis होगा, फिर it is going to damage the duct and it is going to cause the disruption of the duct, which is going to lead to a duct ectasia later on. So how are you going to do if there might be a subareolar location? So what happens beneath the areola? अगर तुम breast की anatomy देखोगे, if you are going to see the anatomy of the breast, the most least resistance area, so the breast with the least resistance area is going to be the subareolar region. So subareolar region में breast को actually least resistance रहेगा. So any abscess over near the duct, it is going to come and it is going to settle near the preareolar region. So any subareolar abscess, don't treat it as subareolar abscess. Find out the location from where the pus is trickling down. So antibiotics though, stop smoking, USG guided aspiration of pus, send for culture and sensitivity. And if it is more than 2 centimeters, you can excise the duct. So if it is more than 2 centimeters, you can go for a duct excision. So excise the 2 centimeter proximal to the duct. So it is very much important. Subareolar abscess अगर देखोगे तो subareolar abscess, it is a complication of periductal mastitis. Just we talked right now. Here also you are going to go for USG guided aspiration. If not settling, you can go for IND. Very much important disease for you to know. Sir, idiopathic granulomatous mastitis. So I have seen a patient who was diagnosed with a breast lump, and she went to 4 to 5 different surgeons and then came to us. One of the surgeon did an excision of that breast lump, and that the diagnosis was still not conclusive. So this was a diagnosis of idiopathic granulomatous mastitis. So it is a benign self-limiting condition of Corynebacterium which is implicated on a non-caseating granulomas on histology. So whenever you find out a lump which has a non-caseating granulomas on histology, it is a condition called as idiopathic granulomatous mastitis. Here you can go for a biopsy. Why? Because it might mimic malignancy, and you can do a gram staining because it might be associated with underlying TB as well. And there might be some NSAIDs or first line therapy already वो patient को जा चुकी होती है, and then she comes to you. But always remember that idiopathic granulomatous mastitis is going to respond very much to the steroids. So if you are going to give 2 steroid doses, the lump is going to subside. And if TB comes positive from that aspirate, you can go for ATT blindly. So you can go for ATT, but do not give the ATT blindly. Do not give the ATT blindly because it can cause worsening of it. So always important for you to know. So tubercular mastitis. So TB of the breast is rare. Cold abscess might be there. So AFB is necessary to rule out the caseating granulomas. Give ATT for 6 months and then 6 to 9 months, and then the scar can be healed, or it might go for a chronic abscess. So always AKT is the treatment of choice when it comes for tubercular breast abscess. And then comes the duct ectasia. The duct ectasia, there is the dilated subareolar ducts more than 3 mm. It is because we saw that inflammation रहेगा, periductal mastitis रहेगा, so naturally it is going to cause the fibrosis. And here you can go for ciprofloxacin and metronidazole for 2 to 3 weeks. If there is abscess or fistula, you can go for Hatfield's duct excision. So basic benign disorders, it's very much important for you to know. So now we are going to talk about other inflammatory conditions. Macromastia. So when the breast is going to be more, the size of the breast is going to be 2 more, it is disproportionately bilateral breast hypertrophy, causes neck and back pain, skin rashes and intertrigo. So between the breast folds and the skin there might be a rash which is an intertrigo, and treatment is going to be a reduction mammoplasty. So both the breast, uska volume kam karo and you are going to go for a reduction mammoplasty. Traumatic fat necrosis. So अगर कुछ trauma हो गया breast को, तो it can cause which is called as a traumatic fat necrosis. Only 50% of the patients can recall that type of trauma. Seat belt injury might be there. So it might be from a pectoralis, or USG mammography will go for an irregular mass. So USG देख के तुम्हें conclude कंक्लूजन नहीं पता चलेगा कि इज इट मैलिग्नेंसी और नॉट. सो बायोप्सी इज गोइंग टू कंफर्म दैट देयर इज गोइंग टू बी अ ट्रॉमेटिक ब्रेस्ट नेक्रोसिस एंड नो ट्रीटमेंट इज रिक्वायर्ड हियर. सो ट्रॉमेटिक फैट नेक्रोसिस, no treatment is required. What is Mondo's disease? A Mondo's disease is when there is going to be a single, the vein is going to be hard and prominent vein is going to see. It is a superficial thrombophlebitis of the thoracoepigastric vein. So कौन सी vein है? It's very much important for you to know. Which vein is important in Mondo's disease? The important vein is the thoracoepigastric vein in the Mondo's disease, which is a cord-like tender structure, and it is a self-limiting condition. Usually resolves on NSAIDs. You don't need to go with anything else, and exclude the underlying breast cancer. So any disorder which presents on the breast, first rule out the underlying breast cancer, and then label it as a benign disease, and then NSAIDs can be given to treat this Mondo's disease. The vein is important. It is the thoracoepigastric vein which is going to be the cause of Mondo's disease. Important for you to know. So I hope it is clear. So if it is very much clear, we are going to stop for the day because we have completed the benign breast disorders. Malignancy, today was enough of the hammering. Basic things to take home, the basic things which are going to take home. Yes, whenever you are going to talk about the breast, the anatomy is important, the axilla is important, the nodes are important, the investigations are important. MRI कौन से breast में important है, कौन से patients में important है, MRI, that is very much important. What is the tissue diagnosis, which tissue is important, if FNAC, कौन से patient में FNAC करने का, biopsy के indications क्या है, biopsy कौन से patients में करने के, and on that what are the biopsy guns required, 14 gauge and 18 gauge needles of very much important. Vacuum assisted biopsy is a recent advance which is going to pull out the lesion. अगर palpable lesion ही नहीं है तो vacuum assisted biopsy भी उसका कर सकते हो. I hope it is clear. Then we came down to ND. ND में हमने देखा कि at the time of development of the breast, when the patient is going to have the when the patient is going to be in the reproductive age group and when the patient is going to be in the post reproductive age group. Fibroadenoma during the development, 25 years, nothing to worry. More than 3 centimeters, go for excision. More than 30 years, go for excision. अगर breast cancer is there, family history में breast cancer है, तो early excision is always warranted. Early excision is warranted. Why? Because family history of breast cancer is going to increase the fibroadenoma conversion to malignancy 4 times. We have seen that. Then we saw what is called as the cyclical mastalgia. Cyclical mastalgia में लखनऊ कार्डिफ स्कोरिंग इंडेक्स 1, 2, 3, 4, उसमें अगर ब्रेस्ट को नोडुलरिटी है तो इट इज नॉट गोइंग टू गो विद द इवनिंग प्राइमोरोज ऑयल, तो उसके लिए हमें ऑर्मिलॉक्सिफेन या फिर सिलेक्टिव एस्ट्रोजन रिसेप्टर मॉड्यूलेटर ऑलवेज एंड ऑलवेज देना ही है, ऑलवेज इंपॉर्टेंट. देन वी सॉ अबाउट द cysts ऑफ द ब्रेस्ट. तो इन द लैक्टेशन एंड ओव्यूलेशन देयर माइट बी सिस्टिक फॉर्मेशन ऑफ द ब्रेस्ट. तो वो सिस्ट कैसे रहेंगे? सिंपल सिस्ट, कॉम्प्लिकेटेड सिस्ट, कॉम्प्लेक्स सिस्ट. व्हाट इज द मैनेजमेंट? सिंपल. Then benign disorders में inflammatory disorders, ductectasias, nipple discharge. So how is the patient going to present? First is a nipple discharge, then there might be some inflammation of the breast or a breast abscess, which we saw, and then we saw what is called as a Mondo's disease. So very much important for you to know. Other benign disorders like macromastia, polythalia, amastia, Poland syndrome, वो सब चीजें pediatrics में cover हो जाएगी. So ये सब चीजों को पता होगे तो breast, benign disorders of the breast, the anatomy of the breast, the axilla, this is more than enough for you to know, even at the UG level, even at the PG level. I hope it is crystal clear to you. If you have any doubts, you can just ping me up. I'll be more than happy to help you. Thanks. Good night, Gaurav. Good night. So, मिलेंगे कल. ठीक है? Tomorrow we'll complete the breast carcinoma. So, breast will be a complete wholesome disease. If you have any doubts, you can post me up. ठीक है? Till then, take care. Bye bye.